Dear colleagues and friends, I'm going to present the PRF in aesthetic medicine, plastic surgery and dermatology. All indications and procedures are presented. You'll understand why you should move to PRF for your procedures in the future. I will also introduce the interest of immunology in regenerative medicine. Enjoy. PRF, platelet-rich fibrin, in plastic surgery, aesthetic medicine and dermatology. In 1998, it was the start of the concentration of the blood in order to get platelets. This concentration was named PRP by Marx, and in 2001 I came to introduce the PRF. What is PRF and which difference we have between PRP and PRF? About the content of the tube. In PRP we have anticoagulant and gel. In PRF we have no anticoagulant, no additive, no gel. Nothing in the tube. What is the speed of the centrifugation? PRP uses a high level of speed, 1500 G. PRF uses a low speed from 60 to 200 RCF. Though the injection is painful, yes, with PRP the injection is painful because the pH is acid. With PRF, the injection is painless because the pH is normal. Both PRP and PRF are medical device class 2A. And finally, the cost. PRF has a much less cost compared to the PRP. PRF, the principles are simple. We collect the blood, we spin it, and then at the end we have a clot in the red tube and a liquid into the purple tube. But both of tubes don't have any additive into the tube. The evidence is enough today with more than 3,000 applications on PRF. Since now 25 years. We use the Duo Quattro centrifuge, and what we see is this centrifuge has different presettings to prepare different kinds of PRF. Just one information, on the right side you have a very small size here, and if you introduce a forceps into the side, you can open the lid in case of power failure. So, you see, opening the lid with the forceps. In a centrifuge, the tubes are balanced, and then we have holders with different core in order to make an easy balance. We can put 2, 4, 6, but this centrifuge has 12 holders. Then we can use 3 or 9 tubes. If the tubes are not balanced, we will be shaking, and this shaking will damage the machine. We need to stop to make the balance and then to restart. Otherwise, the machine will be damaged, definitely. Why to spin at low speed? The low speed centrifugation concept. When we spin at high speed, the G-force is high and then the cells are pushed to the bottom. If we reduce the G-force, then we can get more cells at the level of the supernatant. This is the concept of the LSCC. But we can see, as we decrease the force, as we increase the platelets count. As we decrease the force, as we increase the white cells count. But who is releasing the growth factors? The cells. And then if we increase the cells, we will increase the release of the growth factors, VEGF, for example, and TGF-beta. This study was made in London at the Queen Mary Hospital, and we see that if we compare two kinds of tubes, 3 of PRP, 1 of PRF, we see that the speed is really high with PRP and PRF is not using any additive. The first is to see the amount of platelets. 3 times more platelets, which is good. 6 times more white cells, but also 6 times more red cells. This is why the liquid is not yellow, the liquid is orange, because there are still some red cells inside. But it doesn't matter. For me it's good, because these cells, they have a potential. And the multiplication is by 2, which is good regarding the biology. About the white cells, because I'm focused on the white cells because of their immune function. We see the monocytes, we see the lymphocytes, but the most important cells are the neutrophils. And there are 7 times more in the PRF than in the PRP. But the interest is not only on the white cells, the interest is on the mesenchymal stem cells. It was my objective, and this is a study we did in the university in Nice, trying to search the markers of the stem cells. We know that a stem cell must have these 6 signals. 2 are negative and 4 are positive. And then the result is really amazing. 1 to 2% of the cells in the PRF are mesenchymal stem cells. It's a huge amount of stem cells. Just to understand the relationship between the speed and the quality of the liquid. At medium speed, we have 25 times more stem cells. But at 700 RPM, we have 200 times more. And this is the concept and the benefit of the low speed. The low speed is giving us a very rich liquid, not only in stem cells, but also in platelets and white cells. I would say this is really a blood concentrate and not a platelet concentrate. And this is different. I prefer to use a blood concentrate. Even when we harvest the bone marrow and we spin it, if we spin it at low speed, we will get more cells. But in the blood, we have not only stem cells, we have all the progenitors, fibroblastic, endothelial, hematopoietic, and also obviously mesenchymal. And then when we spin the blood, when we collect the IPRF, we have all of these progenitors. What is the function of the mesenchymal stem cells? The main function is to modulate the immune and inflammatory response, making healing and regeneration. This is the goal. This is the function of the stem cells. But what is the best method to push the stem cells to come into the blood? Physical exercise. We know that when we do an exercise, the bone marrow releases the stem cells into the blood. And this is why doctors they advise people to make exercise. But why we do not the same for the PRF? This is first the first test of IPRF. It was a 10 ml tube, and then I introduced the 13 of the purple tube, which has almost 2/3 more stem cells into the liquid. But if we ask the patient to walk before the blood collection, he will have 50% more stem cells into the blood, and obviously into the PRF. And this is why I ask very often my patient to walk 15 minutes around the building before to come to the appointment. We need to know the exact condition of the blood collection. First, the blood sampling must be fast, must be quick, because there is no anticoagulant. 10 to 15 seconds maximum per tube. And then when we end the collection, we need to make it immediately the centrifugation, and obviously the centrifuge is close to the sampling area. What happens if the collection is made slowly for the red tube? But, if we take more time, the blood clots, and then the fibrogen is consumed. At the end, the clot will be smaller. This is the main cause of failure in preparation of solid PRF, the speed of the collection. When we compare two tubes, one is collected fast and one is collected slowly, we don't have the same amount of fibrogen at the end, because it was a consuming of the fibrogen during the collection. When we want to prepare a PRF liquid, what happens if the collection is made slowly? The blood clots fast into the tube. Then, at the end of the speed, the supernatant is clotted. This is again the main cause of failure in PRF liquid preparation. The second condition for the blood collection is to use the pump pack. What is the principle? Cooling the blood to slow down the clotting. How to cool the blood? We will use a cold tube. And how to make the tube cold? We store it into the fridge or the freezer. And then, if we want to maintain the tube cold, we will use a pump pack, which is a cold pack designed as a tube holder. And then the pump pack and the tubes are stored into the fridge, simply, or the freezer, if you want to increase the liquid phase time. Then, when we remove the tubes from the packaging and from the fridge, we put them immediately into the pump pack in order to stay cold. Then, we collect the blood, we take the tube from the pump pack, and it comes back to the pump pack again. Because the concept is to make the coolest tube with the pump pack. At the end of the collection, we put the tube in the centrifuge and we start the speed, the program. When we want to make a clot, you see how the clot with the pump pack is bigger, because we are facing less consuming of fibrin during the collection. For the liquid, it's the same. We use a pump pack, but for what? In order to increase the liquid phase to almost, or I would say at minimum 1 hour. We remove the tube from the packaging and we go to collect. Collections quickly, as you know, and at the end of the collection we put the tubes into the machine and we start the speed. At the end, we remove the tubes and we put them again into the pump pack. Come back to the cold situation to stay long. In order to collect the PRF, we take a needle and a syringe and we make the aspiration. We can also put the syringe into the pump pack in order to stay cold. So, the third condition for the blood collection is to use a butterfly. Please never use a syringe to collect the blood. Please never collect the blood through the catheter, which is used for the general anesthesia or for sedation. We have two separated ways. One is for anesthesia and one is for blood collection. We have three kinds of tubes available: red, green, and purple. To produce a clot, means a solid PRF, we name it the PRF matrix. We use the protocol 1300 RPM, 14 minutes, and at the end we have a clot. We remove the clot from the tube, we scratch the red cells because we don't need too much, just a little bit. And we put the clot into the box, the PRF box. Removing the clot with the forceps, we scratch the red cells and we put the clot into the centrifuge. Then we use a tray to cover and to press, and we wait 1 to 2 minutes. After 1 or 2 minutes, we have the membranes available, and we will use these membranes in different indications. We will come back later. We can make a liquid with the green tube and we name it SPRF. But you see that the settings are the same as the APRF. Why? Because with this liquid we will prepare the sticky fat and the sticky cartilage. And we have the purple tube. The purple tube we run at 700 RPMs, 5 minutes. And this tube is the tube that will give us the best quality, means the higher number of cells, platelets, white cells, stem cells. This IPRF, we remove the cap and then we remove the liquid with a syringe and a needle. But the question is, at what level do we stop here? Should we get a little bit red liquid in order to make a bit more reddish? Yes. Yeah. Don't worry to aspirate a little bit of red cells because it's very good and it works very nice. Don't be obsessed to get just an orange liquid. There is an important difference between men and women. You know that the red cells in men are more than in women. Women, they have almost 10% less red cells. And obviously the volume will be less. And this is why when you spin the blood of a woman, the supernatant will be bigger. Always with women. In men, they have higher hematocrit, and sometimes you can meet a very small supernatant. Don't worry. We know that it's a man. You make the diagnosis of high hematocrit, and then you need just to spin again 1 to 3 minutes. You have one position on the machine, which is IPRF. It's 3 minutes more. You can select this setting. The benefit of the PRF is on the production of collagen and cell migration. Definitely, PRF is making better action on the cells mobility and on the collagen manufacture, but also on the growth of the fibroblasts. Then we can talk about the different protocols. The APR protocol is to make the clots and membrane. We use it in wound healing, in membrane, for example, in aesthetic, in surgery, in lifting, breast surgery, rhinoplasty, abdominoplasty. We put the PRF at the wound closure time, subcutaneous, or we can use also deep, for example, in abdominoplasty. The function of the PRF is to reduce the wound healing time. Then you will meet a faster closure, all the time. Another example is to use the PRF membrane during a rhinoplasty just below the skin, because we know that the skin is traumatized during the surgery, and we help the skin to heal faster and better. We can mix the liquid with fat or cartilage. This is what we name sticky fat or sticky cartilage during reconstruction surgery. Or we will use the liquid for skin rejuvenation and hair loss. With the S, the green, we can make the sticky fat and the sticky cartilage. The process is almost the same. For cartilage, we use the PRF to stick the cartilage fragments. In order to meet a faster integration of this cartilage grafted into the nose, it's a huge paradigm shift in the graft of the cartilage. Today, with the sticky cartilage, definitely you will meet much better outcomes. The principle is to add the liquid to the cartilage, cut in small pieces, and then we form a gel, and we will cover this gel with membrane. For the sticky cartilage, this is the protocol. You need one green tube and two red tubes, both. How to gelivate the liquid? The liquid, we can use a syringe, or we can use a needle to collect the liquid. Then we put this liquid on the cartilage. In this video, we show you just a biomaterial, but it's exactly the same, just to understand the handling. We put the liquid, but this liquid will not clot immediately. It takes 30 to 45 minutes. If we want to clot, we need to go to the box to take the liquid, the exudate from the clots, and to add to the SPRF. And then it clots in 1 or 2 minutes maximum. Then we take this gel and we will, design exactly the size, the shape, the thickness we do. We handle this sticky cartilage as we want. First is to squeeze it all the time, and then we go to fold it. We can fold it 2 times, 3 times, 4 times. The objective is to design exactly the shape that we want to use and the thickness. So 1 green tube, 2 red tubes. Okay. Now we have the 3 tubes. We spin them one single protocol. And at the end of the spin, we have the 3 tubes. We remove the cloth, but we don't put it into the box. We put them on a tray or in a bowl. You will understand why at the end. Then we have 1 tube. We have the cartilage. Here I show you with granules, but it's the same handling. We get the liquid from the tube and we put it in the bowl. Okay. But now we need the exudate. And this is what I'm showing you. The liquid is going out the clots naturally. Then we take this liquid and we put it on the PRF. And then it will clot in 1 minute. We have now the gel. Let's go to design and to shape. First is squeezing all the time, squeezing as much as possible. Then you can go to fold it 1 time, 2 times, in order to have exactly the size that we want to use. Okay. Then we take the cloth. This is why we didn't put it into the box, because we want to stick it to the sticky cartilage. When we squeeze the cloth on the sticky, it sticks to the sticky. If you use a membrane, the membrane will not stick. One side, and the other side, we take the cloth. It's too big, we cut it, and then we go to put, and then we are making a sandwich of a sticky cartilage between 2 layers of fibrin. What is the goal? Is to make a very dense, a very stiff, sticky, you see? This is the best to achieve the goal to graft the cartilage into the nose. Just a demo with another, you see, we have a gel, and the concept is to design exactly the size and the thickness that we want to use on site. We can make 3 forms in order to fold it easier. And then you see that we design exactly what we want. But we can make the same with the fat. The PRF liquid is mixed with the fat coming from aspiration or nanofat in order to meet a better stability of the fat grafted. Yeah, we have publications showing that when we mix the fat and the PRF, we have a better integration. Then we can prepare a sticky fat for surgery. What does it mean? We mix the fat and the liquid, the PRF liquid from the green, in order to stick. But the fat doesn't need the exudate, because we have clots fragment into the fat, and then the mix will clot spontaneously. But if we want to make an injection, we need to be careful, because we cannot mix PRF and fat. Otherwise, I told you it clots. We need to inject first the fat, and then we inject the liquid. We never mix them into the syringe. So, I want to show you sticky fat used during a cervicofacial lifting. What is the goal? The goal is to design the cheeks. And when you have very nice cheeks, we can say that it's very nice outcome. The key of the success is the cheek. And when you achieve it, you have a very nice result. Cervicofacial lifting, we pull the skin, but it's not very static. But we need to redesign the cheeks. And then you have a very natural result. We can use for rejuvenation and hair loss all kinds of injection. micropapules, filling with needles, with cannulas, but we need to make the second action, which is the spray of the PRF and microneedling, systematically. Any kind of action you do on the skin, you need to make also a microneedling. Whatever the type of injection, whatever the site, face, décolleté, scalp, there's microtrauma. They induce an important inflammation, which is the start of the regeneration. We can also inject into the site in pre-op, like in this case, for the rhinoplasty, we inject the IPRF in order to prepare the site to heal faster. How many injections? Classically 2 to 3, but there is no rule. From my side, when we want to achieve a goal, we need to inject maybe more than 3. But if we inject and we don't have any improvement, we need to stop. Let's go to see the skin rejuvenation. Yeah. If we can inject, if we can stimulate, if we can create inflammation with the microneedling, then we can do everything. Rebuilding the derm and the subderm and giving a very nice aspect of the skin surface. It looks almost as a lifting. We can reduce the wrinkles. We can improve the lips. We can fill the wrinkles and improve the skin aspect. This is only with PRF injection, microneedling, and spraying the PRF during the microneedling. Again, we can make filling and subdermal treatment with IPRF, but we need to add the microneedling. The same for filling. We can treat the acne. We can repair the acne scars, but again, injection and microneedling, and spraying the PRF on the skin. This is the classic vampire lift with a very nice outcome on the acne scars. This is again another case of acne scars. Another case. Dark circles are making an amazing improvement. Look, only in 3 days, how the color of the skin is changing. Only in 3 days. Obviously, the injection is made by the cannula. How to use the PRF as a filler? We can use it alone, or mix it with fat, or mix it with non-crosslink HA. I like this technique, to mix non-crosslink and PRF. Why? Because the HA stays during 10 to 15 days. But during these days, it's a scaffold for a regeneration. And this is how the synergy is very, very powerful with the PRF and the non-crosslink. Mixing with fat, as I told you, be careful. You need to inject the fat and then to inject the PRF after. But now we can make a filling on the cheek. Again, the cheek. This patient has VAH positive, and then we can rebuild the fat on the face. We can make a lipostructure. How to prepare the filler? We will use 4 tubes, and we will make 2 PRF liquid. First, we fill 4 tubes, and at the end of the 5 minutes, we remove 2 tubes. And this tube will be used for injection and microneedling. The 2 tubes left in the machine, we spin them again with the protocol A PRF liquid. Let's go to see. First is 4 tubes. Okay. We spin them. At the end, we have 2 tubes that we remove from the centrifuge, and 2 tubes are staying into the centrifuge, and we spin them at A PRF liquid here. And at the end, what is the goal? Is to get much more liquid. Because when we do a filling with PRF, we need to make an overfilling. You see, we need a lot of liquid, but don't worry, because when you use PRF and you make an overfilling, you will never meet an over result, never, because the liquid shrinks, clots, and the fibrin lose a part of the volume. Then you cannot meet an over treatment with the IPF. Filling the wrinkles, and then today we use also the PRF to repair the nerve damage, mostly after complication of botulinum toxin. We know that we can meet the ptosis, and the decision is to inject PRF and to give them vitamin D. 2 days, we see that we are getting much better opening. And at 10 days, the result is almost full. This is an interesting way to repair a damage. The mechanism is very simple. With the stem cells, we know that we can accelerate the healing. Then the nerve is healing quickly. That's it. For the hair, when we do the PRF, we increase the number of hair and we increase, but we don't increase the follicle. We increase the size of the hair and the number, the same. After PRF, we increase the number and the volume. How to treat? First, we take 2 tubes, we inject one, and one is used for microneedling again. We need always to make the trauma in order to start inflammation and regeneration. You see? Drop by drop, we put the PRF on the scalp and we use a long-term microneedling. But at the end, please don't wipe until the next day. We need to leave the fibrin on the skin during the day after the procedure. And then we can see the outcomes. Androgenic alopecia, you see, number and volume is better. Number and volume is better. Same. Result is really nice. Other examples. More volume, more hair into the follicle, and the same. So, don't forget that vitamin D is responsible for healthy hair. We know that vitamin D stimulates the hair follicle. Alopecia is due to vitamin D deficiency. And if you make a supplementation, it will promote the hair growth and will improve the hair quality. What is the strategy in hair loss? Means medical treatment. We need to make an immune stimulation all the time. Minimum is vitamin D. We need to make the microneedling mandatory. Injection of sole PRP or PRF has no sense, as the stimulation is important, as the regeneration is powerful. Then we will use all the cells of the PRF, platelets, white cells, stem cells. Topically and by injection. You know now the concept. Injection, microneedling, spray. but we don't clean after the procedure. Discussion about the laser low energy. We have evidence that it improves the angiogenesis, then why not? I recommend also to use a topical solution because we know that the follicular receptors are more sensible after the PRF. We will prepare in the pharmacy a solution of 50 ml, base is Choukroun, and this is the content. Minoxidil, dutasteride, and tretinoin. They take 1 ml by day into a small syringe and they put it into a cotton and they make the application on the skin daily during at least 3 months. But when we do the hair graft, it's a bit different. Same stimulation with immunity, at least by the vitamin D. We need to stimulate the donor site. How? Injection and microneedling. Management of the grafted zone with PRF. First is when we do the injection of the donor site, we do the injection of the recipient site in order to prepare the site a few hours before to the graft. At the end of the graft, we need to spray the liquid on all the grafting area. Why? Because we need to have a clotting of the liquid on the area. And this PRF clot will help the hair graft to heal faster. We don't clean? Never. The question is, should we stimulate before? 1 week earlier, for example. Why not, I would say. Again, same, injection and microneedling of the recipient site. The most important is the recipient site. Should we use laser? Of course. Why not? We know the positive action from the laser. But the question is, should we make a late stimulation? From my side, it has no sense. No sense. Because you must know that if the graft is successful, it works. If the graft is not successful the day of the surgery, even if you inject PRP or PRF a few weeks or months after, it will not change the behavior and the outcome of time. We need to make everything the day of the surgery, the day of the graft, not after. We can also use the PRF for chronic wounds. What is wound healing? Wound healing is a natural mechanism, but the question is, who's in charge? The blood. Always the blood, only the blood. We know that the blood has 3 functions. It brings the nutrients, it brings the healing elements, and it's an active biomaterial. What does it mean, active biomaterial? Active biomaterial, when it goes out the vessels, it clots. You know, during many years, the blood is liquid. A few seconds after moving out the vessels, it clots. This is the specificity of the blood, and this is why we say this is an active biomaterial. Because this clotting is the primary hemostasis, and it's the start of the wound healing. The clot is formed after an injury, and this clot will induce the healing by the release of the growth factors. Yeah. If we put a material under the skin, mix it just with blood, we see how much the implant bed vascularization increase. But this is exactly what I'm asking you to do when I advise you to mix hyaluronic acid and PRF. You have a scaffold, and you will get a lot of vessels into this scaffold. And we know that Hyaluronic has also an anti-inflammatory action. We know the cells, they release growth factors. The platelets, after clotting, they release all the cytokines. The white cells, they release the cytokines, inflammatory cytokines, and most of them are angiogenic. Let's go to see how is the healing. This is a chronic wound after a Lyell syndrome, and we decided to apply the fibrin clot. This is the first PRF I did in my career. Only two applications, and 1 week later the infection is gone, and only 1 month is enough to heal. This is adhesions after amputation in a diabetic person. Application of PRF will help to heal in 1 month. We know that it's not possible, usually. This is a very nice indication for diabetic ulcers. A lady who was aggressed by a dog, it takes 1 month to heal. This is typically, a wound that cannot heal. Why? Because it's too deep and it's at the place of a very high level of tension. We cannot close. The only one condition to close is first to fill the gap. How to fill the gap? With the PRF. Because the fibrin will keep cells in order to make a new connective tissue. And when you fill the gap, you can close the site. But it takes 4 months. We have sacrum scars, we have diabetic wounds. This is really impressive how to improve the wound with PRF. This is a cancer of skin, and then how to rebuild the skin with the PRF, and look at the final result. How to use in a chronic wound? We put the fibrin or we put the membrane, but the concept is just to press a little bit the clot in order to stick it. This is how we put the clots and we stick them to the wound. We press a bit and then the clot sticks. Then how to cover? Very easy. We use the envelope of the butterfly. Inside it's sterile, then we make a small piece of plastic. We can use also aluminum sheet, and then we cover and we make the dressing. It's very simple, but this dressing we don't touch for 4 days. What is the protocol? We collect the blood, we spin a PRF, then we put all the membranes or the clot. It's not necessary to cover the full wound with membranes. We cover with a plastic foil or aluminum to maintain the site wet. This is the objective of the plastic, is to maintain wet during the 4 days. We put some gauze and make the dressing. We don't touch for 4 days. I'm using this technique since 25 years and I didn't change because it works very well. And 4 days we remove the dressing. We can repeat PRF or we can just repeat the current dressing. The classic schedule is to 1 session every 8-10 days. It's very, very rare to make more than 5 procedures. This is my experience since now almost 25 years. My friends, I hope that you got enough information about PRF in different situations, different indications, different fields, and you understand now why and how you should move to PRF in the future. You will come. Bye. As I told you before, now I'm showing you the role of immune system in wound healing and regeneration. We have a frequent question. Why two medical procedures with the same doctor, same materials, same protocol, don't have the same follow-up? It depends on the patient health. Can historical research help? The patient condition is often mentioned. What is a patient condition? It's the status of the patient immune system. Example of influence of immunity on health. We know that if you go to a doctor, he will advise you to make physical exercise because it improves the patient health. Why? Because when we do exercise, we mobilize the mesenchymal stem cells from the bone marrow to the blood. And what is the function of the mesenchymal stem cells? Is to modulate the inflammatory and immune response. Means they make anti-inflammation and they help for healing and regeneration. Let's go to analyze the physical exercise. Means walking, but it depends at which speed you are walking. This paper published in the British Medical Journal is showing a study about two populations of adults, 70 years, walking at two different speeds. Half at 3 km per hour and half is walking at 5 km per hour. 5 km per hour means 3 steps by seconds. And they followed the population during 5 years. After 5 years, people walking at 3 km, there is no survivor. 0. People walking at 5 km are all survivors. It's unbelievable how the speed of walking is conditioning the life. But why walking at 5 km is better? Because it's the speed where you can mobilize the stem cells. We have another information about the influence of physical activity. Golfers. In this paper, they show that golfers are living 5 years more than current normal population. And professional golfers, they live again 3 years more. We know how are working the golfers quickly, every day, and this is why they are living more. So, the immune system is involved in all stages of healing. Immune cells contribute to the early stage of angiogenesis. Immune cells are the key regulator in wound healing. You need to know that we have two immune systems. One is the innate immune system, the system we're born with. It helps for the defense against microbes, and the function is tissue remodeling and wound healing. What are the cells? White cells, mesenchymal stem cells, and recently we discovered the innate lymphoid cells. And then you understand why I'm always focused into the increase of the cells into the PRF. Because the cells are helping the healing and the regeneration. And we have the adaptive immune system, we say acquired. The T lymphocytes are responsible of the cell-mediated immunity, and the B lymphocytes are producing antibodies. Wound healing starts by inflammation, which is an immune reaction. And this inflammation will lead to recovery and new tissue formation. But we need to understand what is inflammation and how it should stay. The information that we don't have yet is that this inflammation must be brief, should last maximum of 5 days. During the first 5 days, the inflammation is always beneficial. It's the positive inflammation because it activates the repair genes in order to produce antioxidant, because with the antioxidant, the immune system is efficient. However, if the inflammation persists, it becomes harmful. And we say this is a negative inflammation because it increases the production of oxidant. And with more oxidant, the immune system becomes efficient. And then the wound healing is compromised. You should remind all the time, as long as inflammation persists, the healing is postponed because of the persistence of release of inflammatory cytokines. Inflammation must end at the 5th day, otherwise the healing is not achieved. This is the case of the keloid, because of the persistent inflammation into the skin. After surgery in the knee, patient is staying with pain during several months because inflammation persists. And then the knee cannot heal. If you stop the inflammation, then the recovery is very quick. How the cells repair? The mechanism is very simple. We need to activate the repair genes. We have in our cells 500 genes specifically dedicated to the reparation. And how to activate these genes? We have a protein. It's the nuclear related factor 2, the NRF2. And this protein will activate the antioxidant production in order to stop the inflammation. This is how we start it, by the antioxidation. One interesting information is how to activate the NRF2. Vitamin D is the most powerful activator of this pathway. And you understand that vitamin D is playing a very crucial role in the healing. We talk about oxidant. What is an oxidant or free radical? It's a molecule that has lost 1 electron or more. And then it becomes highly toxic. What is an antioxidant? It's a molecule able to provide 1 or more electrons to a free radical in order to neutralize it. And this is the biology. We need to have a balance between oxidant and antioxidant. We produce continuously oxidant during the redox reaction, and then we need to produce continuously antioxidant in order to stay into the balance. But sometimes we can't. We produce too much oxidant. We don't produce enough antioxidant. And we name this situation oxidative stress. Oxidative stress leads to major cell tissue. Oxidant, they attack the cell's membrane and the DNA. And then the white cells are damaged. If the white cells are damaged, immunity is not going well. And then the healing is compromised. This is how it will lead to higher rates of failure or complication. You need to have in mind all the time when you are meeting bad outcomes, any kind of bad outcome, it's because it was a high level of oxidant induced by a long-term or intense inflammation. And then we know what is the outcome: immune deficiency. Easy to understand why we get more infection. But we know that when the inflammation is staying long, fibrosis will occur. Yeah. All time when you meet fibrosis is because you met a long-term inflammation. What are the origins of oxidative stress? Too much oxidant or not enough antioxidant? So, now with immunology we can explain most complications. Why diabetic and smokers are meeting more complications? Because they are in oxidative stress. Diabetes is first a chronic inflammatory disease. Diabetics are deficient in vitamin D. What is the issue with the smoking? It's the smoke, because the smoke breaks down the antioxidant of the gut, of the skin, of the lung. And this is why the smoker's skin is bad. This is why the lung of the smoker is moving to cancer, because of the chronic oxidation. But they are also deficient in vitamin D. Chronic inflammatory disease, they have a high level of inflammatory cytokines, and then they are meeting an immune deficiency. They will meet more infection and failure. Allergy to penicillin. Allergics are meeting an increased risk of surgical site infection, 50% more. If we replace, it's logic to replace penicillin by another, but even if you replace, they will meet 3 times more failure. What does it mean? It means that we need to understand the mechanism, the pathway. First, allergy is a dysfunction of the immune system. And what happens during this allergy? The T lymphocytes are releasing a lot of inflammatory cytokines, and we know what happens. Too much inflammatory cytokines means increase of oxidant production. But allergics are also deficient in vitamin D. They cannot produce enough antioxidant because they don't induce the NRF2 pathway. And then it's easy to conclude. Allergics are in oxidative stress, and this is why they will meet more infection and failures. Osteonecrosis of the jaw. What is the main cause? The immune dysfunction-related pathways associated with medication of bisphosphonates. These bisphosphonates, they disturb the mucosal and osteoimmune homeostasis. And then we mean the impairs of the body's ability to resist to infection, leading to osteonecrosis. Then how to enhance the immune response? First, by increasing the antioxidant. Because with the antioxidant, we can stop the inflammation. The first is to use the vitamin D in order to activate the NRF2 pathway. Yeah? The target of the NRF2 is the genes. And when they activate the genes, then we see the production of antioxidant in order to neutralize all the oxidant. Vitamin D is the most powerful activator of the NRF2. I'm asking since 15 years the doctors to make a systematic pre-op testing of vitamin D and to involve a systematic supplementation. What is the pathway? We know how it is. We get the vitamin D by diet or by sun exposure, and then go to the liver and the kidney in order to to be on 2-hydroxylation, producing an active hormone. Vitamin D in our blood is an hormone, and then it has an endocrine activity and a paracrine activity producing antioxidants. And this is the interest of the vitamin D, is the immune function. What are the levels? Minimum is 30 nanogram or 75 nanogram. Take care, because you can meet in the paper on the lab test nanogram or nanomole, but it's not the same level. 30 nanogram means 75 nanomole. But most of the population is deficient. From the American Endocrine Society, the minimum is 40 nanogram. But look at this study made in the north of France. Almost 1/3 of the population, young, healthy, is very deficient. Means we need to test. But why deficiency is so frequent? Because today we are living with clothes. We don't expose too much our skin to the sun, and this is why we are all deficient. Below 20 nanogram, the deficit of vitamin D is playing a causal role in the systemic inflammation. But we have other activators of the NRF2. We know the vitamin K, it enhances the vitamin D efficiency. We know the antioxidant function of the vitamin C. We know the antioxidant hormone melatonin, and the zinc is very, very important, because when the patient has a zinc deficiency, there is no immune response, zero. But we have other pathways to make antioxidation. We know the influence of the microbiota on immune response. We know the role of the vitamin D in anti-inflammation, of the copper, of the magnesium on inflammation and oxidation, and the omega-3, very powerful anti-inflammatory without side effect. We have so many products, but it's possible to boost today the immune system, improving the patient immunity and repair capacities by a cure. And this cure exists today, it's the immune force. The immune force made by immune pharma is a cure of 2 months. Taking 1 pill of each vial, containing all the product that I showed you before, starting 1 week before. This is a very, very powerful help in order to improve the immune system and in order to meet much better outcomes. But we can propose to the patient autophagy. What is autophagy? Also, we got the Nobel Prize in 2016. When the cells are in fasting, they organize their own cleaning and eliminate all unwanted substance, including oxidants. It means that when you are in fasting, you are making your own detox. We have the evidence today that autophagy improves innate and adaptive immune system. We have the evidence that autophagy accelerates the wound healing through angiogenesis. Then, how to induce autophagy? In our patient, by intermittent fasting. Simply. What is intermittent fasting? Fasting at minimum 16 hours, from 8 to 12. Is it difficult? No. You just need to miss the breakfast. Forget the breakfast and you will be on intermittent fasting. What is our protocol? We ask the patient to start 5 days before and to maintain 5 days after. Just missing the breakfast. But you will be surprised how many people that you advise them to start intermittent fasting, they will come back to say, hey doctor, you know what? I'm feeling very well, I will not stop. This is the goal. To good feeling. Should we use cortisone? Of course. Use of steroid is beneficial. Because the cortisone shortens the inflammation time. One single dose. We give them in pre-op. 0.5 milligram per kilo or 0.1 milligram for dexamethasone, which is injectable. It makes sense to order physical exercise, walking 30 minutes by day at 5 kilometers per hour. We ask them to start 5 days before, as long as possible after the surgery. And again, you will meet a lot of people coming back to say, hey doctor, I'm feeling better, I will not stop. My conclusion is, please never neglect the relevance of immunity. Vitamin D serum level testing must be systematic and supplementation. But you see that enhancing the immunity will improve mood. Thank you, my friends.